colleague, Dr. And I will give it away to Sasha for her to introduce herself as well as the topic.
Thank you, Jason, and hello, everyone. Welcome. Thank you all for spending your lunch hour with me to talk about the fun and exciting topic of trauma and parenting. I promise to try to make this as engaging and as interesting as possible and hopefully have an enjoyable hour with you guys. So I want to just quickly introduce myself and my style of presentation. I will try my best to read along to messages as you guys type them, and I might ask some questions along the way, and I'll try to respond to some of the things that you guys type while I present. So I'll try to multitask as much as possible. So my name is Sasha, and I am a clinical psychologist here in New York. I'm also the clinical coordinator for a research study conducted here at the McSilver Institute called the Safe Mothers, Safe Children's Project. And what we're doing here is focusing on moms who have a history of trauma and who are involved in the child welfare system. And so the topic of trauma is something that is very close to my heart, as well as something that is very close to the topic of our research. We're being funded by the Annie Casey Foundation and Robin Hood, and the study is being led by Michael Lindsay, who is also the director of the McSilver Institute, as well as Claude Chemtop, who is the co-PI. We're specifically targeting moms with PTSD who have children between the age of 3 to 6, and what our study is trying to do is focus an intervention to help mom develop skills to learn how to regulate her emotions in order to reduce trauma symptoms and therefore increase her ability to have a better uptake of parenting skills. And our overall goal is to reduce recidivism back into child welfare. And so that's the study in a nutshell in a very quick slide. What I hope for today is to be able to provide some overview of the impact of trauma and particularly how trauma impacts parenting. It's a very broad topic, and so I promise we're not going to be able to touch on everything, but I will try to highlight a couple of key points. One being the importance of developing a parent's insight into knowing that she or he is not abnormal and that what they're experiencing is a normal response to an abnormal experience of trauma. The second is to highlight the importance of safety. Oh, let me switch to the outline slide, I apologize. So if anything, I hope those are the two things that we really come away with from this presentation. So we'll review childhood trauma and outcomes, how trauma impacts adults, and particularly how symptoms of PTSD can present in parenting, and then how we can actually help the parents that we work with in session. So a lot of research has been done on the area of trauma, and like I mentioned, we won't be able to cover everything today, but in particular, what we know is that when an individual has experienced trauma, it can result in psychological problems later on in life. And for instance, childhood trauma has been associated with adult depression, substance abuse, and dependence, as well as, of course, PTSD. We know that trauma can also cause impairment in functioning across many different roles. And what you'll find for much of this talk is I will be focusing on mothers, although at times I will be talking about both parents, mothers and fathers, but in particular a lot of research has been done on the impact of trauma in mothers because for a lot of families that are run by single family households, moms tend to be the main sole provider. Also, by virtue of being female, we know that women are more at risk of experiencing trauma that is more interpersonal in nature. And so if we look at a Venn diagram of the two, parenting and trauma, women tend to have or show up in greater numbers as compared to men. Not to say, of course, that men don't play an important role in parenting. So I'll try to talk about both, but I will be talking about moms for some of the research that I present. And so when we think about parenting and trauma, it's important that we talk about both, because if trauma can impair functioning, there's probably, arguably, no greater role for a person than that of being a parent. And so we have to understand how trauma can interfere with parents' ability to not only effectively parent their children, but also to enjoy their experiences. And so if we look at this slide here, we see in this funnel a bunch of adverse childhood experiences. And this comes from the ACE study, which I'm sure many of you guys know about, but I'll quickly just do a quick overview of. The ACE study is funded by the CDC in an attempt to understand the impacts of childhood stress and trauma and their relationship to future health problems. The study found that as the number of ACEs increases, so does the likelihood of problems, and so in particular, it's a strong predictor of later death, or early death rather, disease, increased health risk, difficulties with social functioning and well-being, and increased medical care costs. So if we just look at this slide, and these are just a sample of some of the things that some of your clients may experience, I want you to take a look. How many of you guys have clients who have only one of these childhood experiences in their history? If you have only one, you can just type in yes. And then I want you to also take a look at it and think, how many of you have clients that have just two? Or maybe 4 or more of these. If you're anything like me, you're working with clients that tend to have multiple of these adverse events experiences, and very rarely do I only see a client that presents with just one of these experiences. And that's because an unfortunate fact for many of the clients we work with is that trauma tends to not occur in isolation. And a lot of our clients have experienced multiple traumas in the course of their development, and probably more traumas that are even able to be listed on the side just due to space. For instance, if we look at domestic violence, which is oftentimes a very gender-based form of trauma, we tend to see that that's also highly correlated with physical and sexual assault for the individual, as well as abuse for the children, oftentimes associated with stress related to poverty and unstable housing and so on. And so when we think about these things, it's not so much about focusing on just the big trauma or the big stress, but all the relationships between the minor stressors and traumas that may impact an individual. Studies on ACEs have shown that adults who have experienced 4 or more of these ACEs, such as the ones listed on the slide, are 4 to 12 times more likely to suffer from alcoholism, drug abuse, and depression. And even those who have experienced at least one have shown that a 69% increase of childhood trauma, which is then an increased risk, puts them at increased risk for high-risk behaviors as an adult, including, for instance, unprotected sex and smoking, as well as a lot of different health conditions related to chronic illness and heart disease and cancer. So oftentimes what this means is that we're dealing with families who face the most burdens, but who may then have the least resources and the least opportunities for healthy models of parenting. In regards to parenting, when it comes to experiencing ACEs in early development, those who have experienced multiple ACEs have shown a reduced parenting capacity or potential maladaptive responses to their children, and we'll go into that in more detail. Understanding the impact of ACEs allows us to move our focus when we're working with clients to what's wrong with you and shifting that instead to what happened to you. So again, we're moving away from what's wrong with you to what happened to you, to have an understanding of how an individual's trauma symptoms are a manifestation of what they've experienced. And a DV is referring to domestic violence. I shortened it just for sake of the slide space. Thank you for asking. One thing I want to point out is that just because somebody has a history of one of these experiences or any type of childhood trauma does not necessarily predict or guarantee future maltreatment of children. That is one thing that clients often say to me, well, if I've experienced these things as a child, does that mean that I'm going to be a bad parent? And no, of course the answer is not. And one of the things that we know from the literature and research is that the presence of at least one stable attachment is a huge protective factor, which should really fuel the work that we do with our clients, because we're helping to support ongoing protective factors for the future generation. So in order to talk about later on in development in terms of adulthood, we must first talk about the early childhood experience within the home environment. our early home life and family interactions really lay the foundation for us to be able to develop an internalized model of our world. And we all maybe have our different feelings about science, but in a way, as we develop, we're all little mini scientists. And by that I mean we're all learning to make predictions about the world and relationships. And we tend to err on the side of caution. So for instance, if you touch a hot stove as a child and you burn yourself, all you need is one experience, hopefully, to learn that that is an unsafe thing to do, and you might learn to quickly avoid touching a stove or a hot burner because you don't want to hurt yourself again. So again, we're pretty good at making very strong predictions when it comes to safety, and this allows us to develop an internal working model. And what this means is, or what I'm referring to rather, is our expectations and beliefs about ourselves, about others in the world, and about our relationship between ourselves and others. And so this type of internal working model is going to contain expectations about our own behavior and other people's behavior, whether or not I'm a lovable person or worthy of love, or whether or not other people are even able or willing to protect and support me based on my early experiences with my parents. When our early home life involves chronic and complex trauma, which I'll explain in just a second, a child may start to develop this internal working model that is distorted and viewed through a trauma lens. And so all potentially relationships might be avoided, especially those that are more demanding or more emotionally heavy, because a child might want to preserve her normal state of mind. So if relationships are scary, it makes sense that I will avoid them. Or if I feel like I'm really good at being able to handle abusive relationships because potentially my parents were abusive, I might be more willing to enter into an abusive relationship because my safety tolerance is lowered. I mentioned complex trauma, and I'll just quickly go over what that means. So complex trauma is referring really to a developmental type of trauma that occurs earlier on in life within the context of interpersonal relationships and attachments. So in this case, the source of support, typically the parent, is also the source of trauma. This is probably one of the most harmful types of trauma there is because it is a very confusing trauma to recover from. It's also one of the most common traumas that a person will experience in their life. And it's, for example, interpersonal violence or interpersonal trauma. It increases the likelihood that a child may actually be suffering from the same trauma source as their parents. So if mom is experiencing domestic violence, child is also witnessing the domestic violence with mom. This can be a very confusing topic here, and I know for the sake of time I'm quickly going over things, so please don't hesitate to ask questions. I'm happy to continue to explain this. The next thing I want to focus on is how trauma early on in life will impact ongoing relationships. And we first have to talk about attachments. And so early childhood trauma can cause problems for adults in their ability to initiate and then maintain secure relationships throughout their life. And without this safety net of a secure attachment, children can eventually develop into adults and then parents who struggle with low self-esteem and emotional regulation difficulties within their relationships. As humans, by virtue of being human, we're social beings, and so our attachments develop as part of our natural connections to others, and this happens regardless of trauma. And so for those of you who work with children, just think about how children show they are attached, regardless of trauma. So we typically see a child might show attachment to a parent through touch, wanting to hug, smiling to show excitement or shared enjoyment with a parent, maybe feeling restless or upset when a parent leaves, depending on the age. Children with a secure attachment display a normal level of distress when a parent leaves, and this is really famously shown in Mary Ainsworth's study of the strange situation. In the context of earlyhood trauma, we know that a child might develop certain specific attachment styles that are due to trauma and that will, if left unchecked or unresolved, can have lasting results into adulthood. So one study that was conducted used the Adult Attachment Inventory. This is an inventory which asks parents to describe their childhood. And in the study, moms with and without a history of trauma were asked questions about their childhood. And mothers that expressed a realistic sense of their childhood experiences and a resolved history were then observed with their children and were found to have what was known as an observed secure attachment style, in which the child showed a normal level of distress and mom responded within the appropriate range of responses. However, moms that were then asked questions about their childhood and described their past in either an overly positive way or denied having any memory of their childhood presented as more dismissive. And these moms tended to rely heavily on defense mechanisms and also tended to detach from events or interactions with their child that might trigger really strong negative emotions. And this was done in order to keep the mom's ability to cope in place so that she wouldn't become overburdened. So if we think about how this might actually present in a parent-child interaction, we can think about a parent who is very uncomfortable with expressing strong emotions. This parent might avoid either expressing her own needs or might avoid having her child express their own needs. So for instance, this parent might stress the need to become very independent very quickly and also might avoid saying things like, I love you. And for instance, I love you can be seen as a sign of weakness or insecurity too. Another example of moms were those that described their history and had an unresolved feeling of trauma or described their history with strong feelings of anger or resentment. These moms tended to have a preoccupied style. And in this case, they tended to be more hyperactive or presented in more of that fight or flight mode when with their child. And this might be because their early signs of closeness while growing up were so enmeshed with negative experiences and emotions. So for instance, this might have been a household in which a parent grew up where all feelings were expressed through yelling. So again, how might this present within the parent-child context? This type of parent might express or might teach their child that relying on others for their needs to be met is a really important thing. So it's important to become dependent on other people. And the best way to do this is to show extreme emotions. So crying, screaming are the best way to get your point across. And all other more quieter signs of distress can be ignored. These styles of interacting, I want to stress, do not indicate that a parent is bad or that a parent is uncaring. And it's really important that I point this out, especially when we work with parents and young children. We might see things that can be really distressing and make it hard for us to be in the room with our clients. But if we remember that a parent is not bad, but rather a parent is just responding to their own history of trauma, it can allow us to have a little bit more patience and understanding. Early childhood trauma oftentimes leaves a parent without many models for what healthy parenting is like. And a child growing up in this context might have lacked opportunities to learn positive skills. And so one thing we'll hopefully have time to talk about a little bit later on is how we can help clients to increase their awareness of how their symptoms are impacting their parenting abilities, because this is the first step towards change. So next, I want to talk about one of the most important relationships, which is that of parenting. So because trauma can impair an individual's own emotional regulation, and by this I mean their own ability to, one, recognize the feelings that they're feeling, and then to do something about it, whether it means take a deep breath or express their anger or frustration, it can also impair how a parent models their emotions and then perceives and responds to their child's emotions. And in fact, a lot of research has supported this. So going back to those preoccupied moms, the ones with the unresolved traumas, they're more likely than other moms without this type of trauma history to interpret their child's attachment-related affect as a sign of a child's weak dependency. And so a mom in this situation might project messages that are really confusing to a child. So if a child cries in sign of distress, a mom might respond with anger. Those moms, again, that are dismissive have more difficulty understanding and responding to emotions. And so this might be a parent, in fact, who says a similar quote to the one that's posted on the slide, not really knowing why their child is sad and not really knowing how to deal with it. Preoccupation and defensiveness both can make it really hard for a parent to identify and discriminate a full range of emotional expression in a child. This picture on the slide is taken from an assessment called, or a workbook called I Feel, which shows a variety of different images of babies and infants. And I chose one that was purposely ambiguous. So I want you just to take a second here and just take a look at this picture, and if you feel comfortable, there's no right or wrong answer here, just say what you think this child is feeling. And while you're saying, while you're typing, I'll continue to talk. In one study that looked at this, parents with and without a history of trauma were shown a variety of pictures, such as the one above, and moms with no history of trauma described this ambiguous picture in a variety of different ways. Some said curious, tired or sleepy, interested, happy, or shy. But mothers, sorry, lost my train of thought for a second, but mothers with a history of trauma, however, tended to view this picture in a different way. They tended to see this child as more fearful or cautious. And the reason why might be because parents are projecting their own unease. A potential consequence for a parent in the situation is that they might constantly be on guard or on alert for signs of distress in their child. It also might mean that a parent is not able to truly enjoy parenting in a calm fashion. But if we also then think about the consequences of this child, for all we know, this child might just be a little sleepy. And now mom is freaking out, wondering what's wrong. It could be very confusing and potentially even scary for a child who's not able to express themselves nonverbally in a meaningful way to their parent. We know in particular that moms who are at risk of maltreatment or abusing their own children display less awareness of their child's range of emotions as well as their own range of emotions. And when you ask these parents how their children feel, they tend to only rate their infant as either happy or angry, and they don't have a lot of vocabulary for that gray area or the middle range of emotions. One thing that's really interesting and that could potentially be used as a strength is that moms with trauma are actually better at identifying fear responses in children than moms without trauma. This means that if this kiddo is really in danger, a mom with a history of trauma will better be able to and quickly be able to identify the trauma than other parents. The problem is that when you have difficulties regulating your own emotions and you perceive your child as in danger, you tend to become overwhelmed really quickly. And that will lead us into our conversation of symptoms of trauma, or PTSD, and how these symptoms impact parenting. So PTSD consists of a cluster of symptoms that fall under different categories. I have a couple of them up here. One is related to re-experiencing trauma, in which an individual might have unwanted memories. Another might be avoiding the trauma, whether that's physically avoiding the place in which the trauma occurred or people that remind you of the trauma, or it might also be associated with avoiding feelings related to the trauma, which oftentimes results in numbing yourself or feeling emotionally numb. And then the other cluster of symptoms is this hyperarousal, in which you sense danger or threat everywhere you go. And I want to focus on just a few key points related to parenting in particular. So for parents with trauma histories themselves, parenting can be a trigger itself because it forces the parent back into the world of childhood and family. And it can actually force a parent to remember what it was like to be a child themselves without someone protecting them. And so potentially when you're dealing with a child then as a parent with trauma, triggers can be unavoidable. And so these triggers as they occur, for instance, a child crying or a child coming home from school with a bruise, these kind of triggers or emotional responses can be really frightening for both the parent and the child, especially for the child because he or she may not understand what is happening to their parent in the moment and may feel as though their parent cannot adequately care for themselves. A parent might respond with an instinctive fight or flight to their child behavior like crying. So for instance, if we think about the world that I work in, which is the child welfare world, oftentimes a client might say to me that when their child cries in public, there's this immediate fear or anxiety that a parent has, that the parent will get in trouble, that people will observe them on the street and think that they're inadequate, which heightens the mom's or dad's response to the parent in the moment. And a parent might then respond with anger or with frustration. And a child then will learn that crying is unacceptable, or that crying is maybe one of the best ways to get attention from their parent. Another potential trigger, and this is especially true for children that are the product of sexual assault or rape, is that pregnancy can be a trigger. Pregnancy is a time of serious loss of physical control over the woman's body and requires that a mom have a lot of physical closeness to her baby, such as during times of bathing or breastfeeding. And pregnancy and birth can occur at the same time that the parent is still adjusting to their own trauma history. And so these parents might see the child themselves as a trigger or reminder and might subconsciously see the child as someone to blame and may associate the child with the anger or abuse of the person who assaulted them. A parent in this situation might say that every misbehavior of their child reminds them just like their father, for instance. In regards to avoidance, parents with these types of symptoms might present as flat or as depressed. And oftentimes we'll see cases of neglect that are really cases of avoidance in which a parent is overwhelmed with her own trauma history or her own trauma symptoms that it's difficult to attend medical appointments or take the child to school. In regards to hyperarousal, in which a parent sees threat in many different situations, it can make it really hard for a parent to be present in the moment with their child and can be associated with this fear that a child will get hurt or a fear that the parent themselves might actually do the hurting. This sometimes comes up for me when parents are changing their baby's diaper. If they had their own history of sexual abuse, a parent is so on guard or on edge that they might actually inappropriately touch their child, which will then potentially lead to an avoidance of changing diaper and then medical neglect for diaper rash, for instance. And this would be an example of how some of these symptoms can overlap in their presentation. Another way that we can see trauma symptoms present in parenting is that a parent might become very overprotective and show a lower frustration tolerance. A lot of energy is used up in these situations when a parent is aroused, and therefore less energy is there for the parent to just be present and play with their child. And so if you take all these things together, we can see that these symptoms can make a parent seem really hard or uncaring. But their presentation is actually a really adaptive way of them coping, or maladaptive way rather, of them coping with the things that have happened to them. At the time when these symptoms developed, they were adaptive because they helped the parent as a child survive their situation. But now as an adult, they're interfering in a parent's ability to feel comfortable and happy in their role as parent. it's important to point these things out to a parent that you're working with, that these are signs of PTSD or signs of trauma and not signs of a bad parent. I can't tell you how many times a parent will come to me and say, I'm just crazy. They describe their experience as feeling out of control or that there's seriously something wrong with them. And there can be no greater relief than just knowing that you're not crazy, that what you're experiencing is actually a result of PTSD. It takes the blame away from you as an individual and puts more power in your lap because you're now able to do something about it. Another thing that's important to help combat some of these PTSD symptoms is psychoeducation about the parent's own trauma history, but also about normal childhood development. This could help to reduce some of the hyperarousal a parent might experience when a child cries, for instance, or when a child has a tantrum. And we'll talk about that in the later slide. The next thing I want to talk about as related to parenting is parenting beliefs. So just as I talked about when we had that slide with the house, our early worldview is shaped by our early childhood. And our internal model of the world can show up in our underlying beliefs that we have about everything, especially our beliefs about parenting. Our beliefs are not only formed in our early development, but they're also formed in the context of culture and community, as well as interpersonal violence and trauma. So, for instance, a parent who has the belief that children are the future may have a certain parenting style. This might be a parent that really pushes or encourages academics, as an example. For those of you who work with parents, just take a moment to think about what are some of the parenting beliefs of the parents you work with. How do you ask this question? This could be a very weird type of question to ask a client. Something that you might want to do or consider is asking parents about their own childhood. What was good? What did they wish was different? You might also want to ask your parents what they think their own children need to develop into a strong student, or what their child needs to feel good emotionally, or what their child needs to feel good physically or to be healthy. And this can tap into some of the parents' own beliefs about what they need to do as a parent. What we know is that parenting beliefs are very closely related to parenting styles. So for instance, if a parent has the belief that the world is a really tough place and children need to learn early on to protect themselves, what type of parenting styles might we see? And you could feel free to chat here, and this also might remind you of some of your own clients. What we might see is a parent who's a little bit tougher on their child, or a parent who doesn't really welcome or respond well to signs of distress or signs of emotional weakness or affection. The next example is another type of parenting belief of a parent who has their own rough childhood and who had an experience of being in and out of foster care and has their own child who is going through that. Once the child is returned into the home, this parent really wants to try to make their best effort to make up for all the hurt. So this is a parent who believes that she's guilty or he is guilty for the pain in which their child has experienced. So we might see this parent having a very permissive parenting style in which they're trying to overcompensate for some of the things that have happened to their own child. Another type of parenting belief is that a child will go out of their way to manipulate a parent, to push her buttons on purpose. This parenting style might be one of either just complete indifference and avoiding, to the point of potentially exploding when a parent is no longer able to regulate their emotions. So by identifying parenting beliefs, you're better able to, in a deeper, more meaningful way, change parenting styles, because it's not enough just to tell a parent how to parent their child or different ways of parenting if you're not also getting at their core beliefs of what it means to be a parent for their child. This also allows you to really tap into some of the childhood experiences related to trauma. Absolutely. So higher expectations, like in the first example of children are the future, can lead to a parent that sometimes maybe overly pushes a child in a way that doesn't matches the child's own emotional developmental needs. Definitely. The next thing I want to talk about is safety. When I mean safety, I don't just mean physically safe. I think if we all pay attention to our surroundings, we're pretty good at understanding what it means to be physically safe. We make sure that we lock our doors when we leave our house. We don't have our wallets sticking out where somebody can grab them. We maybe avoid certain neighborhoods or walk around during daylight hours when we're more comfortable, and so on. Emotional psychological safety is something that can be a little bit more tricky to discuss, especially with parents. And so this is not something you have to answer publicly, but just take a moment in your own personal space to answer this question for yourself. How safe do you feel in this moment? And if you are at a certain level of safety, what's helping you to feel that way? Or if your level of emotional safety is lower, what's getting in the way of having it be a little bit higher? The reason why I'm asking this is because individuals with trauma have impaired relationships, which we've talked about. They also have difficulty regulating their emotions, which we've also briefly talked about. But trauma can also impair someone's ability to recognize and identify when they're safe. And taken together, these three things can have a really big impact on the parent-child relationship. So when we think about emotional safety, what that means is I have the ability to overcome what's going to happen to me. I have the ability to regulate my own emotions so that I don't become overwhelmed or I don't drown in my anxiety or my fear. I have the ability to enter into a relationship and choose the correct partner or trust myself, trust my instincts when I think my partner is not safe. For a parent with their own unresolved trauma, the ability to make clear and appropriate judgments can become really impaired. And so a common reaction to unresolved trauma in regards to safety is when a parent has difficulty assessing risk in the partners that they see or date or are involved romantically with. It becomes harder for parents to then form and maintain secure and trusting relationships. And this can be really unfortunate for their children because then they're not able to be an effective model for their children. This also, unfortunately, puts children at potential risk for future victimization. So if a parent is now dating someone who is abusive, we know that this puts the child at increased risk for their own case of physical or sexual abuse or neglect. Another thing that's difficult about unresolved trauma in regards to safety and emotions is that if you're not able to feel safe in your ability to regulate strong emotions, you might get really good at not feeling them. And what I mean by that is you might get really good at avoiding strong feelings. And if you're unwilling as a parent to experience emotions, it could be really protective because you don't easily get overwhelmed. But you might feel less capable to handle your child's signs of distress. And you actually will then, in result, feel less in control in situations that are developmentally normal, like a child having a tantrum, for instance. And then, unfortunately, you're not then able to address your child's own emotional needs. So safety, again, is a huge area of need and intervention when working with individuals with trauma, both physical safety and emotional safety. I want to talk about what we can do next. I'm being mindful of time because I want to save time for questions. But in terms of what we can do, the first thing is ask. I'm sure you might have heard, if you don't ask, you don't know. And so it's important to at least start the conversation by asking the individuals we work with about their history. Because trauma can alter our core assumptions about the world, we might be willing to accept that a person might question the relationship with you as their therapist or clinician. And so disclosure of personal information might happen really slowly at first. And entering into a therapeutic alliance with you as a provider might also be a little bit slower. But the more that we ask, we're modeling the willingness to be able to talk about these things. And one way we can do that is to ask open-ended questions. And even if you get short answers at first, it gives you a lot of information that you can use to guide the work that you do with the parents that you work with. Psychoeducation, like I mentioned earlier, is also really important. But psychoeducation is really just a fancy word for teaching. It came about as a tool for mental health providers or professionals to combat some of the stigma of mental health disorders. I mentioned earlier that many of my clients come in describing themselves as crazy or bipolar, for instance, or that there's seriously something broken or wrong with them. There is a sense of relief sometimes when I explain to them that what they're experiencing, whether it's extreme rage or avoidance, is a very normal reaction to their past trauma. So something I sometimes tell my clients is that because they are so normal, they're actually experiencing PTSD symptoms because they experience something that no person should ever have to experience in their life. And this helps the person to understand that they are not bad and that I don't see them as bad. It allows them to be a little bit more compassionate with themselves and to realize that all parents make mistakes and that their past allowed them to develop skills to help them cope. And that what we're going to be doing in the course of treatment is to develop new tools in addition to the ones that already exist to better cope with the present. It's also really important in psychoeducation to, at every moment you can, strengthen a parent's insight as to how she's behaving in the moment with her child and how her trauma might play a role. If parenting is a mirror to a mother's own internal thought process, her interactions with her child is telling you a lot about her internal working model. So for a parent with PTSD who is not conscious of the past and the impact it has, this mirroring might reveal a world of internal struggles. And so by helping to strengthen a parent's awareness of their own mental health needs, we help a parent become more conscious in their parenting. And we could also help them become more present in the moment so that they can enjoy parenting and create a really safe and enjoyable experience for their child. The last thing I want to talk about in regards to helping parents is in the development of a strong working alliance. We might present as experts in certain areas, whether it's trauma or development or a specific disorder, but it's really the parent who's the expert on her own history and also her child. And so we want to stress that the parent enters into the room with a lot of knowledge that we don't know. We want to accept our clients with no judgment, understanding again that they have learned to survive the world in a way that was really successful for them, to be able to overcome a lot of hardship. And so rather than removing all of the symptoms or presentations that they present with to help them survive, we're just going to add to them. So that the next time they have a very stressful or scary situation, they have a lot of skills now in their toolkit. Another really great way that we can build a safe and collaborative relationship with our clients is to constantly check in. One thing I always do with my clients is ask how safe they feel in the moment. I'll ask them how it felt to open up with me, how safe it felt to be able to be sharing with me and to be in a relationship with me in the context of the work that we do together. Another thing that we can do is to, I'll actually go to the I'll save the video, sorry. Another thing that we can do is to try to strengthen a parent's own self-compassion, to take the time to reflect on her own stress and her own coping strategies, and to even carve out time in the day to be able to engage in some self-love. It's really hard and very stressful to be a parent, even without a trauma history. And so to be able to have a personal pat on the back is something that can give a parent a lot of strength moving forward. Lastly, we have to remember to take a strength-based approach. The parents that we've worked with can be really challenging as a provider in the sense that it may trigger our own thoughts and feelings. In fact, as a provider, it may bring us back to our own childhood experiences. And it's important to slow down the process and to remember that the parents we work with might have gone through multiple hurdles and stressors and traumas in their past and potentially ongoing in their current adult life. The skills they have in place helped them to survive. Like I said before, rather than throwing these skills away, we're just adding to their strengths so that they can go from surviving to thriving with their child. Due to some technical difficulties, we're not able to show this video. I'm not sure this might look familiar to you, this clip, but this is a really cute video. We have the link for it. It's a video of a mom and a baby interacting, and a mom singing to her child, and in the course of the mom singing, the baby becomes really overwhelmed and responds emotionally. I like to show this video because it's a perfect example of how a healthy attachment and learning can occur in the context of a really secure attachment between mom and child. So as this baby becomes emotionally responsive to her mom, the mom doesn't freak out. She doesn't stop and say, what's wrong, what's wrong? She allows the baby to continue to experience these emotions and to have a resolution at the end. And what she's teaching the child is that the child can feel strong emotions and be accepted by the parent, and that there's always a chance to recover. She's basically teaching the core foundations of safety and emotional regulation. It's also just a really cute video to watch. I've had people watch it who sometimes become a little tearful or respond emotionally themselves. So we'll share the link with you, and I encourage you to watch it on your own time. So this concludes my portion of the presentation. I know, Jason, you were gathering some questions.
Did come in. I'll start with the first regarding really the strengths-based approach. So one of the participants actually asked, what would you say to a colleague that describes caregivers as bad and doesn't use strengths-based language?
Yeah, well, one, I think there's a gut reaction for us to kind of scold the people we work with and say, they're not bad, right? I think to take a step back and acknowledge that what a colleague might be going through is their own frustration. And one of the things that I sometimes recognize within myself and the people that I work with is not so much that it's a bad parent, but it's actually more so the challenge that a person has when they enter into a space as a professional. We oftentimes come in with certain goals, and a parent might present with alternative goals, and that can leave us clashing. And so my go-to response is to actually step back and say, what's been the most challenging aspect of working with this parent, to see if there's something that the person can do to lessen the stress or the load of the work when they're working with this client. Then I would also ask for them to explain what the parent has gone through in their past, to identify some of the trauma responses we might be seeing in the moment, and to really try to actively and consciously notice the positives. And on a personal note, one thing I do is I make sure, almost on a self-timer, to throw out praises to my clients, even if they haven't done anything overtly positive in the moment, because it helps me to reflect my own understanding of what a person has gone through and the positive aspects that they bring into the moment. But really, I think most of the challenges we experience is not so much that a parent is bad, because most parents, I would say, the majority of the parents we're going to work with truly want to be a good parent and truly do love their children, but it's more a reflection of the frustration in working as a professional in this role.
Great, thank you. Another person asked regarding the Safe Mothers, Safe Children study, if you could talk about a breakdown between participants by race or ethnicity, and if there are any trends in terms of disproportionality with regards to trauma.
Yes, that's a really good question and a really interesting one, and very, very important to talk about because we are talking about trauma, and you're absolutely right that trauma is something that is kind of occur across all class and gender, but tends to be a little bit disproportional among some groups. And then layered on top of that, I'm talking about particularly the child welfare population. And so in our study, we have a majority of African-American, it's all women only, African-American women, and then some Hispanic Latina women who identify from different countries. And we also have a minority of immigrants as well. We don't have any Caucasian women at this moment, at least at the time of today. So most of our women are African-American, I would say. I don't have the exact percentage, but I would say probably close to 85%.
Great. You also mentioned asking about safety when you're working with a client or participant. One of our participants actually asked, how often would you do that?
I actually ask every session. I do it a couple of reasons, and I encourage this whenever I do trainings as well, because talking about safety, we realize both as a provider potentially and also as a client, safety is a very vague word to use, and so people don't understand when they are feeling safe or what safety means. And so asking it every session helps you to become more comfortable asking it and checking in. It also helps the client to check in on a more frequent basis. And so I do ask every session. I ask in regards to a couple of things. I ask in regards to how comfortable a client felt opening up to me in the context of therapy. Was it scary to talk about the things we talked about today? And if so, because I work with women, how did she overcome those scary feelings? And then in regards to physical safety, I would check in and do some questions about thoughts about hurting herself or hurting anyone else and feeling like she could keep her and her child safe between now and the next time I see her. Those are more of the standard kind of questions that you ask in clinical settings, but the emotional safety questions are not typically asked. But I really encourage you all to ask them every session because it allows you also to know what maybe you need to do a little bit differently to help your client feel more comfortable.
Thank you. Another question is, could you please give some examples of how to explain to the parent the reason behind asking the questions within the ACEs questionnaire?
Between asking, so I guess it depends on the context, but typically asking those types of questions usually occur early on in the therapy process or the treatment process, maybe during an intake or assessment period. I would frame it as wanting to understand what a client has gone through and explain that many of the clients I've worked with have experienced a lot of different stress, and that one thing I know is that when you experience stress as a child and that stress didn't have a chance to be resolved, then it could really make it hard to function as an adult or as a parent. And so what I'm going to do is present a couple of questionnaires, whether it's the ACEs as well as other intake items that you might have, to get a better understanding of what has impacted the person in the past and what they're still struggling with currently so that we can come up with some really good and smart treatment goals.
Thanks. Another question is with regards to additional resources. So do you recommend any psychoeducation materials to help parents link their past trauma with current parenting beliefs?
Yeah, not off the top of my head in terms of a website, but I know that there, if you go to the NCTSN website, there are a ton of materials related to childhood trauma and also parents. too, and parenting discussions, and that would be a really great place to start. They have handouts related to trauma and how it could impact adults and children, and they could also link you as a provider to different webinars that you can have your parents or clients go to as well. It's NCTSN. That's the one that comes up to the top of my head, but if, Jason, I'm not sure if we think of others, we could potentially share them after the webinar.
Yeah, of course.
Okay.
We can gather some resources and share them as well. And I will type in the website in the chat box.
Thank you.
Of course. Another question is, how do we help parents to understand that their trauma is different from their children's trauma?
So, one, a couple of things. I think that it might not always be so different. Just want to throw that out there. Again, if it's something interpersonal in nature, it might be the chance that the children have also experienced that same trauma. And the reason why I say that is because it is important, if that is the case, that parents become aware of that. Because a parent in pain does not want their child to be in pain. And understanding that their own childhood history has resulted in pain can make them more motivated to potentially change their home life so that their child doesn't experience that as well. Another thing I would do is to help a parent identify what has happened in the past and ways that as a parent they're currently keeping themselves safe, physically safe and emotionally safe. So what are they doing to provide a different type of childhood for their child? Are they engaging in positive interactions and positive play and noticing the positive behaviors of their children, for instance? And that helps, depending on the type of trauma, differentiate the trauma of the past and the supportive strengths that a parent has in the present to keep their child safe. But really, insight is key in identifying memories that might be associated or fear that might be associated with the idea that the child is going to experience the same type of trauma. So identifying when those things happen, and then really great coping strategies to use in the moment so that a parent doesn't become overwhelmed. And that taps into their ability to regulate their emotions.
Perfect. And with that, Sasha, I want to thank you so much for today's presentation.
Thank you, everyone, for your questions, and thank you, Jason and Caitlin, for helping.
Yeah, of course. So everyone, the slides and today's recording will be available before the end of the week on our CTAC website, as will the instructions for obtaining your one contact hour for today's webinar. So just as a reminder, if you are a licensed social worker within New York State or a licensed mental health counselor, you can actually obtain one continuing education contact hour for viewing today's webinar. You would need to go on the NYU Silver School of Social Work Continuing Education online portal. If you have not already registered, you can register, create your profile, select the webinar, and then you will pay the registration fee. And then from there, you'll be sent instructions for how to actually obtain the credit. So thank you again for everyone for participating in today's webinar. Thank you, Sasha, for all of your work. And we hope that you can join us again. Thank you, everyone.
Thank you, everyone.
Bye.